Okay, we're at 11:59. So thanks everybody for joining us today. Just to introduce myself, I'm Whitney Jackson. I'm one of the transplant hepatologists at the University of Colorado, and I have the pleasure of working with just an amazing group here. Also, getting to meet the living donors that come forward for our recipients and seeing just what an amazing difference they make in people's lives. The talk today, I titled The Role of Living Donor Liver Transplantation. What if my patient needs a transplant, but their MELD score is low? And this is part of the University of Colorado's Hepatology Liver Transplantation webinar series, which Dr. Kalra's organized for us. The hope here is to really create a stream of communication and education for our referring population of physicians and advanced practice practitioners, so that we're here to support you and just really talk about some of the things that we're doing here. So it looks like we have quite a few people on. It's noon, so I will get started. And the first thing is just some housekeeping issues. So let me get to the Zoom. Okay. So first of all, I have no disclosures, and this is just documenting that. This is a lecture that you can get one AMA, CME, or MOC credit for. And so the way that this works is that after this lecture, you'll get an email. It'll ask for you to fill out an evaluation form, and then you'll receive the CME or the MOC credits by email or directly through the ABIM afterwards. So we hope that that helps you out also. Okay, so what are my goals for today? I'm talking about the indications for liver transplantation in the low MELD population. When I think about how I can help our referring providers the most, it's really with when to refer. And overall, I'm going to summarize that an early referral helps the patients the most, but I really want to go through and focus with you on the low MELD population and why to refer them earlier. And then, sometimes it probably feels like a bit of a black box. Allocation and distribution are really complicated. They're getting more complicated. I want to show you just some of the challenges that your patient is up against once they are here and once we want to start working towards transplant. I want to show you the role of living donor liver transplantation, and I want to show you some of the unique things that are happening at this center and why this might be a great place for your patient. So I'm going to start with a case. This is a 55-year-old male. He has alcohol-associated cirrhosis. He's decompensated with refractory ascites. His MELD sodium score is 11, and he's ABO type O. So you see that he keeps coming in for weekly paracentesis, and you think that he needs a TIPS. You're thinking about a TIPS, but then you realize, well, he's really had significant hepatic encephalopathy. He was even hospitalized last month for hepatic encephalopathy, and he also has increasing sarcopenia. And so you're thinking to yourself, ooh, maybe TIPS is going to be high risk in this person, even despite that low MELD score. And you send him here for an opinion, and we think that he needs a transplant. But all of us are talking, and we're not really sure how he's going to access organ offers with that MELD score of 11. Okay, so what's the background to this? Well, in 2000, it was mandated on a national level that allocations of organs be allocated based on medical urgency. That's called the final rule, and it's a governmental rule. So the MELD score, which was originally developed to predict 3-month survival to risk stratify for TIPS shunt, was adopted. And over time, sodium was integrated into that. And now we're seeing albumin and sex are being integrated into that in something called MELD 3.0. So that's actually a new thing that came out and is official this July. That's really an effort to try to represent a more urgent need for transplants in females who might not have as much muscle mass and whose MELD might not go quite as high because their creatinine might not bump quite as high. So what I can kind of summarize about that is that our measurements of urgency are imperfect, overlooked and increasingly complex. It's really like a very actively changing world out there. But notably, a MELD of 15 is generally viewed as the minimum MELD for a deceased donor offer, because organs are offered to all candidates nationally before they come back to a local candidate with a MELD score under 15. And that's a policy that's called Share 15. So we're hoping that that policy will change soon, but let me show you why I think it really needs to change. That Share 15 policy originated from data created during the hepatitis C era. At that time, the Michigan group asked this great question: when is the optimal timing of liver transplantation to avoid harm from intervening too early and futility from transplanting too late? And they analyzed the SRTR data, looking at candidates that were added to the wait list between 2001 and 2003. And they found that the benefit of transplant varied across the range of MELD scores. More benefit is obviously seen at higher MELD scores. You're sicker, your alternative is really a high mortality risk on the wait list. But you see here that MELD scores, candidates with MELD scores under 15 did not experience a survival advantage with transplant compared to the wait list. And that data has really informed 2 decades of policy and practice in our country. And I think it's time for that to really change and for us to look at some more updated data. So recently, our group was able to look at the survival benefit for living donor liver transplant recipients compared to those candidates that remained on the wait list. Just similar setup as that last study. And we were able to show that the benefit of living donor liver transplantation outweighs the risks at a MELD score of 11 or higher. And it's important to note that those were candidates that were already listed because they had indications for transplant. But it's updating our understanding of when to pursue transplant, since DAA therapies have come out to cure hepatitis C, and that's really changed the landscape of our population. And so that Share 15 policy is likely to really be limiting patients and their access to organ transplantation. And I also just want you to note something here. The error bar in that 6 to 10 range crosses 1 also. So there's actually probably a lot of people with low MELD scores, even lower than 11, that are benefiting from living donor liver transplantation. So who are these low MELD people that benefit from transplant? Well, we know that some complications from liver disease aren't always captured in the MELD score. What are some examples of that? Number 1 would be portal hypertension. A patient with moderate ascites and a MELD of 11 has an equivalent risk of death as a patient with no or small ascites and a MELD of 16. Who else? Well, we know that portal hypertension, as it progresses to include variceal bleeding, the odds of death increases over time. So you can see this middle column, bleeding varices with no ascites, then non-bleeding varices with ascites, bleeding varices and ascites. The odds of mortality is really increasing as those complications are increasing. And then this is kind of getting at this idea of MELD 3.0 and what it's trying to help. We know that sarcopenia is associated with mortality, and we know that women are disproportionately affected by that. So you can see here that the decreased comparative survival of women on the wait list, as well as the dotted lines showing their lower survival with sarcopenia, those populations are really at risk of mortality on the wait list. So I would kind of summarize, reasons that your patient with a low MELD score may need a transplant. I would say that there are many. Overall, a MELD score threshold of 11 to 12, regardless of complications, is a reason to start referring your patient for to be seen by us. Any complication of end-stage liver disease, regardless of MELD score, ascites, SBP, variceal bleeding, hepatic encephalopathy, there are many things that exist that can get you some standard MELD exception points. So hepatopulmonary syndrome, portal pulmonary syndrome, and some of the cancers. And then there's other reasons like that sarcopenia, where your patient's really sicker than their MELD score, but there is no access to MELD exception points for those people. Okay, so what is your patient up against? Why is this so hard? So you've recognized that your patient needs a transplant for their survival benefit. You've added them to the wait list. And now your patient is not only maybe the MELD score isn't the best indication of their urgency, but also you're adding them to a list where there's a lot of people on it, and a lot of those additions have lower MELD scores also. So you can see here, this purple and green line. Purple are people that are added to the wait list every year with a MELD score of 14 or lower. So those people are really going to struggle with access to organs because of Share 15. And then that 15 to 24 range is in the green bar. And so clearly people are recognizing that their patient would benefit from a transplant, but what are they up against, and why is this going to be challenging? Well, the challenge is that despite the increasing number of transplants performed each year, you've added them to this list where there's a persistent gap between supply and demand, and that's staying really steady as we go through time. So, for example, in 2021, 13% of the wait list died or became too sick for a transplant. And we know that the worst place to be is on a wait list. So on the wait list is where your risk of dying or your mortality risk increases with time. You can even see that this is true for our low MELD patients with MELD scores less than 15. So the dark line, the dark solid line in black, is when your patient has a MELD score less than 15 and isn't transplanted. And then that gray solid line is your patients with those lower MELD scores less than 15 who do undergo a living donor liver transplant. The worst place to be is on the wait list. And our distribution system continues to change and to strive towards improvement, is making a lot of strides, but it's increasingly complex. So in 2020, in response to these geographic disparities that we see in transplant, acuity circles were adopted. And that's the goal of replacing these donor service areas that were previously based on, state geography. These overlapping circles are based on nautical radius miles from the donor hospital, and they're not subject to the same sharp lines that those regions previously had. And the hope is that there's wider sharing of organs and overlap across those lines, and that it'll increase transplants. And so, how does this work as an example? The donor hospital, somebody passes away, unfortunately, their liver is adequate to go to somebody in need on the list. They first look out to patients that are listed as status 1, and then the higher MELD scores first. So if there's nobody who's considered status 1 within 150 nautical miles, then it goes to 250 nautical miles to 500 nautical miles. Okay, if there's no status 1 within that area, you go to a MELD of 40. So the 37s to the 40s are next. And then it goes out in terms of mileage after that. And then it continues in sequence down that MELD range. And so getting down to, a MELD of 15 to 18 to the 150 nautical miles, 250, 500. And really that organ offer goes out nationally before it hits patients that have MELD scores under 15. So early data from the acuity circles show us that it did what it was supposed to do. It got organs to the sickest people, and it increased access to organs to those sickest people. But it again emphasizes just how high of a MELD score you need to have to be competitive for a transplant, while our lower MELD patients haven't seen any increase in access to deceased donor organs. And we show you still, the worst place to be is on the wait list. So the challenges that our patient is up against, he's up against a lot. Allocation is based on MELD, specifically now MELD 3.0. It's used to guide a limited resource. We work within an imperfect system of increasing complexity, and patients with lower MELD scores have difficulty accessing organs and are also at risk for increased waitlist mortality. So where does living donor liver transplant come in? Well, in our national system of organ allocation, it was perhaps predictable that these higher MELD patients were going to get access to deceased donor organs in the blue bars, and that we would need to find something else to fill in for these lower MELD patients, the less than 15, the 15 to 19. And you see here, when we're looking at national access, these red bars, that's where living donor liver transplantation really comes into play. Certainly, I don't want to negate the fact that these blue bars still exist for the low MELD population. One of the ways that that happens is that when there's a deceased donor organ with increased ischemic time, now there's increasing use of pumps to try to make those organs work and be viable for longer. And I do think that has so much promise to help our lower MELD patients. It doesn't change the fact that earlier referral, earlier access to transplant is going to help these people. But I think, just emphasizes that we're really trying to help this low MELD population. And as it is now, living donor liver transplantation is their primary access to transplantation. Okay, so what's the premise behind this? I want you to know kind of what goes on behind the scenes, what we're looking for, how it's approached, and what the recipient and the donor are going through and how some of these decisions are made. So the premise is that living donor liver transplantation is the removal of the recipient candidate's liver, and it's the replacement of a portion of healthy liver from a healthy volunteer donor. That donor undergoes a medically unnecessary major abdominal surgery to do this. We take that evaluation of that donor incredibly seriously, and I'm going to show you just some of the ways that that comes through as we go through this. And it's truly remarkable that a piece of liver can regenerate in both the donor and the recipient to be all that each of those people need. Why is this possible? I always like to kind of contextualize this with kidney donation. In kidney donation, a donor has 2 kidneys, an artery, and a vein. The technical aspect of the surgery where you're clamping that artery and vein and removing the kidney, it's a little bit more straightforward. And then that donor goes on to live with 1 kidney. And so there's a long-term risk from living with 1 kidney. Here, we're looking at the opposite. This is 1 organ. It needs to be divided. It's technically challenging. Our surgeons are true experts at this. And this is possible because of segmental anatomy to the liver. So each segment of the liver has its own blood supply and bile duct. And then when that segment is divided and given to the recipient, the remaining segments in the donor enlarge over time. And so you don't grow back those segments that you've lost, but you hypertrophy and enlarge the remaining segments. That's why you can't donate your liver multiple times. So let me just walk you through this a little bit. You can see here on the right side of the liver. The right side of the liver is about 60%, 60 to 70% of somebody's total liver volume. In general, if an adult wants to donate to another adult, they're going to need to donate that larger portion of their liver, and then the donor is left with the left lobe of the liver. And that's at least 30% to be able to ensure that there's adequate regeneration. Now, the left lobe of the liver, so that's the 40% of the liver, sometimes an adult can donate to an adolescent or a petite female to help that person out. And then this 20% over here is the left lateral segment. And that's when an adult can donate to a baby or a child. So the surgery itself. I'm going to draw your eyes up here to the upper left. So you can see that this is a right lobe procurement. The portal vein, bile duct, hepatic artery have been divided, and then that hepatic vein, which is the outflow of the liver, has been divided. This person on the upper left, they're left with the left lobe of their liver. Now down here on the lower left side, this is an example of the imaging that we generate when we do when we're looking at donor anatomy. So a CAT scan and an MRI are 3D reconstructed by a company called Nevis, and they're able to give our surgeons all the details about the hepatic artery, portal vein, and bile duct. So this is the planning that went in to determine if this person was a right lobe donor. Then it's actually divided, and then on this right side, which is like the pencil drawing, this is where you see the right lobe implantation. So the portal vein is connected, the hepatic artery is connected, the bile duct is connected to a roux limb, and then that outflow is reestablished with the hepatic vein. So I just want you to have an idea of how those connections are made. That's always really interesting to people. So how do we select the right donor for the right recipient? it takes into account a lot of things. First, they need to be blood type compatible. It's just the A, O, B, or AB blood type compatibility. The Rh factor of the positive and the negative doesn't matter, and really there's no HLA matching that's needed in a liver transplantation. So it's just the true blood type compatibility. But we also need to make sure that we're making decisions regarding anatomy, and a lot of those are nuanced. So I want to introduce some of those ideas to you. What do we care about? There's a lot of data to show that graft to recipient weight ratio is what matters. What does that mean? We want enough mass of the liver to go to the recipient so that that recipient is going to do well. And the data would inform us that you need at least a 0.8% graft in general. We also want enough liver left for the donor so that they do well, and they need at least 30% of their total liver volume to be up their remnant liver for that to regenerate and for them to do well. It's also notable that it's not just the size of the graft, the size of the recipient, the size of the donor. The graft size also depends on how, like, quote unquote, sick the recipient is, which is really getting at how much portal hypertension do they have. You could imagine putting a small graft of the liver into a recipient with a lot of portal hypertension. All that blood flow is going to come back to that portion of the liver, and it could really overwhelm it. So some of the complications, if you don't have a large enough size liver, can be something called small for size, where the patient develops ascites after the transplant, or allograft dysfunction, where the liver is just not working well. So we really are taking a lot of these nuances, like how high somebody's MELD score is, how much portal hypertension they have, when we're deciding what's an adequate piece of liver for this donor to do well and for this recipient to do well. So size is always a balance between donor and recipient risk. So for me, the risk and benefit of living donor liver transplant is complex. This diagram represents this fundamental balance of interest in living donor liver transplant and this desire to promote the most net good, which is called utility. You know, the first principle is to do good. That's called beneficence. That's about the recipient and trying to do good for that recipient. The next thing is do no harm, which is non-malfeasance, which is really protecting the donor. And then we take those two variables and put them together in the context of overall utility. And these are the concepts that really underlie living donor liver transplant, but it's notable that really overlying all of this is that idea of autonomy and donor autonomy. Informed consent is something that we take very seriously during the donor evaluation. So I want to talk a little bit about donor risk, recipient benefit. What is the data to show us what those risks and benefits are? So risk to the donor is really related to the size of the resection. The risk of death to a donor has been quoted based on data back to 2010 as 1 in 500. Data before that was actually 1 in 200. It's clear that as a country, as we get more and more experience with this, we are getting better with this, and outcomes just continue to improve. That's also why it's really important to be referring your patients to a high volume center where there's a lot of programmatic experience and expertise. And like I had suggested before, the size of the resection is related to risk in the donor. So a left lobe resection, lower risk of death, lower risk of complication. A right lobe, about 1 in 500 is what we quote, and the risk of complication is 30 to 40%. This is a major abdominal surgery, and that's something that we really focus on with these people that come forward. Programmatic experience, that plays into the selection of donors, the amount of risk that you think is reasonable for a donor, and extent of donor hepatectomy. And what I generally tell people is, this is a surgery that's not medically necessary for you. And so it's our job to be incredibly thorough to make sure that we're minimizing the risks to the lowest risk level that's possible here. And I'll be very honest with donors if we find something that might theoretically increase their risk, even though it won't change their life trajectory, we'll be very honest and say that that might not be something that we're comfortable doing. So overall donor outcomes are excellent. They have very good long-term quality of life, and we've actually studied this. 30 to 40% of donors will experience an early complication, but only 10 to 15% of these complications require an intervention, like an ERCP or a take back. Most donors feel like themselves again by 3 months. That's when the most liver regeneration is happening, although it does go on through that entire first year, and the liver regenerates to be almost its original full size and to be everything that the patient physiologically needs. And 94% of donors express their commitment to donating again if given the opportunity. So just a really rewarding population to work with. They're changing people's lives. They're generally incredibly optimistic. And we have very honest conversations about informed consent in this situation. Oops, I went backwards, excuse me. So what about the recipient? What's that recipient benefit look like? I can show you that on a national scale, we know that living donor liver transplant recipients have equal, if not better, survival outcomes compared to deceased donor recipients, and that's even corrected for their severity of illness. Also, our recent paper showed that recipients gain a median of 15 life years, regardless of the MELD score at which they're transplanted. The nice thing is that you're getting a huge survival benefit despite those low MELDs, and you're probably timing transplant for the lower MELD scores when that patient's able to recover better because they're not as sick, and you don't have that same risk of death on the wait list. What about complications after living donor liver transplant? There are some complications that are increased in this population compared to deceased donor liver transplant. Most notably, there's a learning curve to this. We say that a center really needs to have done 20 living donor liver transplants to have really excellent outcomes, but the rate of biliary complication remains higher in living donor liver transplant recipients compared to deceased donor recipients, regardless of center experience. And that's really because you have a smaller bile duct going into that living donor liver transplant recipient, and the bile ducts are so sensitive to changes of blood flow. So if the bile duct's smaller, it's just going to be more sensitive to some of the changes that are happening. So in summary, I would say these recipients really benefit in that it frees them from our current allocation system. It reduces risk of death on the wait list. It optimizes timing of transplant for a better recovery. Overall, these people are carefully selected and their outcomes are comparable, if not better, than deceased donor liver transplant at a well-experienced center. They gain life years that are comparable to any life-saving procedure. And although biliary complications are more common, they do not affect patient survival. So what does this look like from a practical side if you want to know what your patient is going through? So let me just first say, we meet a patient during their transplant evaluation. I'll tell you what I talk to that potential candidate about. I say, number one, do you need a transplant? What are your indications? What are the things that I'm concerned about with you? What do I think might affect your survival risk? Number two, I say, is it safe? That's why you're here for the transplant evaluation. We're checking your heart, your lungs. Do you have enough support to get through this? Can somebody drive you back and forth when you're not feeling well, or make sure that you're eating well and safe at home? And then in terms of etiology, if your etiology was alcohol, have you been able to show that you can engage in counseling and that you're dedicated to sobriety? So those are all those safety things that we deal with during the evaluation. And then we talk about how. And we talk about how deceased donors are really handed out based on the MELD score in our country. And if I still think that somebody has indications for a transplant, but their MELD score is on the lower side, I'll talk to them and really focus on living donor liver transplantation. The overall point here is to just give them the landscape so that they know that just because I want them to get a transplant doesn't mean I can do that. It means that we're really working within a system where we have to strategize. And then as they get listed and approved for transplant and then listed for transplant, we do multiple things at once. So first they get approved, they go on this list or in a pool of patients that are in need. And we are absolutely always looking for deceased donors for those patients. Even at lower MELD scores, perhaps there might be a deceased donor offer that size-wise fits with your patient that's listed best, or maybe it was put on the pump so that that ischemic time, that liver was really healthier on the pump, so it didn't acquire as much ischemic time, but it's really not adequate for somebody with a MELD of 30, and so it comes down the list a little bit. But the other thing we're doing is we're working in parallel to really engage your recipient or your candidate to say, you know, what do we think, what is the role of living donor liver transplant here? What is your MELD score? What's your chance of getting called? And regardless, let's really engage your family and try to talk about, are there any living donors out there that would want to come forward for you? Could we identify a living donor champion? So maybe your sister or your mom posts on social media that you're in need of a transplant, and people can come forward that way through social media. So once that person is listed, that's when donors usually start filling out this uchealthlivingdonor.org health history questionnaire. There are some situations where we'll bring donors forward earlier than that, but in general, we want to make sure that somebody's listed and really a candidate before we start bringing donors forward. And then what does that look like on the donor side? Well, while your recipient's waiting, your donor's getting worked up. They get screening blood work. They have to have normal liver tests, if they're going to donate directly, they have to be blood type compatible, although we also work on paired exchanges. So we don't limit anybody coming forward because of blood type incompatibility anymore. And if that all looks good, they come in person for a 2-day evaluation. And I compare this to the recipient evaluation. I say, we take the donor evaluation so seriously. That donor is here for 2 days, meeting our coordinators, a hepatologist who is not the recipient's hepatologist. We want to keep that separate. They're meeting a transplant surgeon, social worker. They have their own independent living donor advocate, a psychologist, and a dietitian. And they're getting a ton of testing. And I had mentioned to you that imaging of the liver, the CAT scan and the MRI, and that's really the 3D reconstruction that it can take anywhere between 2 days if we rush it to a week at the longest, so we can see if the anatomy is compatible. And then additional testing based on age and risk factors. You know, we review all of this stuff. Every once in a while, something comes up and we say, we really need to get somebody else's input on this so that we can have a really well-informed risk-benefit discussion with you. And then we give them a final decision between 1 and 2 weeks later. It's really important to note that the donor can withdraw from the evaluation process at any time. And I even say to donors, honestly, if you ever felt like you were uncomfortable with this, I'm good at coming up with excuses to protect you, because my goal when I'm meeting a donor is to be their advocate in this process. So when I put all of this together, I've been working on this kind of conceptual framework, is what we call it, where I'm trying to work on that idea of weighing risks and benefits. And for me, you know, instead of the justice and equity that's needed to allocate a limited resource in deceased donors, in living donor liver transplantation, we have 1 donor to 1 recipient potentially. And because living donor liver transplantation incurs a risk to the donor, we need to quantify the benefit of the donation to the recipient. You know, we don't want to be doing something futile. You could imagine some situations where somebody's so sick, or, you know, like maybe so sarcopenic that they're not even walking. I don't know that we should be putting a donor at risk for somebody if you don't think their outcome is going to be acceptable. And then, so we need to quantify that benefit of donation. And then in order to do so, you know, we look at waitlist survival and the risk of transplant itself, and then the long-term outcomes in the form of life years that are gained. And that all informs this idea of utility to conclude an overall transplant benefit. And that's really what I'm interested in helping patients to define over time. I also want to just introduce this idea of the double equipoise. This is a really interesting kind of ethical framework also. It describes the balance between the recipient's survival benefit with or without a living donor liver transplant and the probability of donor mortality risk. That risk-benefit analysis for living donor liver transplants are not really confined to just the donor, just the recipient, but they're balancing the donor risk against the recipient benefit. And so the concept of double equipoise suggests that there clearly exists an area of excessive donor risk and unacceptable low recipient benefits. Ethical acceptability for living donors to undergo that operation. We think of a mortality risk of greater than 1% is probably not acceptable, especially if the recipient benefit is very low. So conversely, there are situations where the donor recipient balance appears to be ethically acceptable, like an adult donor providing a small left lateral segment at 20% for a pediatric recipient. It would be hard to argue that that's clearly a risk benefit. You're getting incredible amount of life years for a pediatric recipient, and that donor risk is well defined and small. So those are extremes that seem easy to define. And then there's that zone of ethical uncertainty in more complex cases. And so we're always asking, what are the minimal benefits to recipients that warrant the use of a living donor, and how is use of a living donor for extended indications and marginal recipients justified? And so this is actually just a visual of that double equipoise, describing the balance. So donor risk, for a left lateral segment versus a right lobe. And then the recipient benefit increases over time. This blue would be, ethically acceptable. This yellow would be unacceptable, and the gray would be uncertain. And maybe that uncertainty kind of lies in how much risk that donor is willing to take, how much recipient benefit there is, how much the center has experience in this previously. So I just want to show you, in 2022, 17 centers nationally perform 10 or more living donor liver transplants a year. This is us here in the middle. So our referral base doesn't have easy access to living donor liver transplants. There are so many states that aren't represented in terms of liver transplantation around us. And so I think that we're providing a really necessary procedure and option for these patients. You either have to go to the West Coast or the East Coast. We're really in the middle. So I want to go back to our original case, and I want to use that case to demonstrate the roles of altruism in living donor liver transplantation. So a little bit of background, an anonymous donor is a person who comes forward to donate a part of their liver without knowing a recipient in need. They basically come forward to us and they say, I'm healthy, I would like to help somebody, and I would like to do that by donating part of my liver. Can you decide who, is most in need? A directed donor is when a friend, relative, maybe you see on social media that somebody's in need, but you come forward and you want to donate to somebody specific. In living donor transplantation, all forms of donation are altruistic. And this is altruism, throughout. It's the idea of selflessness, benevolence, just wanting to help somebody. And those are the things that a lot of our non-directed donors say. When did this even start for us? I'll tell you that in 2017, a girl named Rebecca came forward to our center. She had been a prior kidney donor and she wanted to donate part of her liver. And she said that she would like to do this to anybody in need. And that had never been something that our center had experienced before. And it was very new to us. And so there are a lot of considerations that we took into play in that situation. Just to go through some of them, she had a history of altruistic behavior. She had already donated a kidney. She was really interestingly grew up in a family where her mother every day before she left for school said, how are you going to change the world today? And so there was this idea of altruism just in her family values that she had grown up with. She was very logical, very mature. There was no expectation of secondary benefits. We felt like we were able to have an informed consent process with her. Her family was very supportive. So these are just some of the considerations that were taken into place in that situation. And I'm actually going to just jump forward to this for one moment. So Rebecca, our first non-directed donor, when she came forward, we kind of went through this exercise with this double equipoise with her. she was 24 at the time. She was a prior kidney donor. And yeah, in her own words, it was, I'm looking to make the world better. And so we went through her anatomy, and we thought that a right lobe on her would be increased risk and would put her into this yellow zone. And we weren't really clear on recipient benefit at the time because we weren't sure who it would go to. It would probably go to an adult. Whereas something like a left lateral segment for us, that was a lower risk procedure and it clearly had benefit to a pediatric patient. And so ultimately we paired her with a 1-year-old with biliary atresia. And that baby, their potential family members had been ruled out for medical and psychosocial reasons. So that baby didn't really have any other options. It's also really notable that pediatric patients that are 1 or 2 years of age are much smaller than larger children. And so they're actually at a disadvantage on the wait list waiting for deceased donor transplants. A lot of the deceased donor transplants that become available might be too large for them. And so you're seeing there that this is a lower on the scale of donor surgeries that she could undergo. A left lateral segment would be the lowest risk surgery for her, but there would be clear recipient benefit. And for it to be our first non-directed case, it felt like we had to do something quite straightforward like that. I'm just going to go back to this. Over time, as our center has gained more experience, these are the considerations that we've taken into account with non-directed donors. Donor considerations are to minimize risk with a smaller graft, and we want to make sure that there's not a lot of technical complexity, and we want to respect donor autonomy. So we'll come forward and say, these are the lobes that you could anatomically donate, and let's have an informed discussion about what the risks are with a left lateral segment versus a left lobe versus a right lobe. Then depending on how that conversation goes in terms of risk and anatomy, we first look at our pediatric wait list at blood type compatibility, size, and degree of illness for those pediatric kids across the street. And then we start looking at our adult wait list. And this is just what we as a center have decided is the most responsible for allocation considerations, considering that those children that are 1 to 2 years of age have increased risk of death on the wait list. And then also those petite females on our adult wait list tend to be really underrepresented as well. So what effect has this had so far? So since 2017, we started that first non-directed donor with Rebecca, and this green dotted line shows really how it's affected the pediatric wait list over time. And this is despite a steady number of referrals and a steady number of transplant listings to the pediatric wait list. So we were essentially able to eliminate it. At the end of the study, there was 1 person left on the wait list, and their insurance was only allowing them to get a deceased donor transplant. That was appealed and ultimately approved, and they had a non-directed donor. And I want to just show you how this has affected both the adults and the pediatric wait list so far. So at the University of Colorado, we have had 66 people come forward to our center and ask to donate to anybody that we think is most in need. That's between 2017 and now. That is a staggering number of people who don't medically need a surgery and are seeking us out. And this is without any advertising at all. This is something that's probably discussed more and more on the radio and in the news. And so perhaps that's how people are learning about it. But we're clearly at a very special place in Colorado where people are coming forward to do this. The next thing I want you to note is we're very careful about our selection process. So about half of the people that come forward are being ruled out for donation. And that might be because of a medical comorbidity that we think might put them at an increased theoretical risk. Maybe it's not psychosocially the best time for them in their lives to be doing this. 6 of these people, the patients learned more about it and just recognized that this wasn't the right thing for them. And there's even been cases where we don't have an adequately compatible recipient. That's usually when we have an AB donor come forward, and AB is so rare that we don't always have a recipient. So, 34 people approved for donation might sound like a low number, but it's making a huge impact. Those people have gone to 20 children. They've eliminated the pediatric wait list. Of course, people keep getting listed, but I'm amazed to see that non-directed donors keep coming forward to us. And then 11 of those people have gotten adults transplanted. And that's helping those adults, and it's helping everybody on the wait list to increase the number of organs that are available. And of those 34 people that have been approved, 16 we call double donors. So they've actually donated a kidney previously and want to go on to donate their liver. And that's an experience that's very unique to us in Colorado. I would say the large volume of non-directed donors here, the elimination of the pediatric wait list, that we're now helping adults as well, and that we have a large experience with people that have donated kidneys and livers is really unique here. So let's go back to our initial case. Our initial case was Chris. He was that 55-year-old male with alcohol-related cirrhosis who we think needs a transplant, but his MELD is only 11. And we're thinking, with Share 15, how is he going to get offers for a deceased donor transplant? This seems so challenging. So there was a non-directed donor that came forward to us and reached out. So his name is Chad, and he's 34 years old. His motivation was this. He basically said, you know, my dad many years ago received a liver transplantation. He remembered as a child being very scared for his dad and how he was going to do medically while on the wait list waiting for that transplant. So he ultimately got a deceased donor transplant. He did well. Over decades, he developed complications from the immunosuppression that caused chronic kidney disease. And so his dad ultimately needed a kidney transplant, and Chad donated his kidney to his father. So he felt that real draw, and he had a good experience doing that and recovered well. His mom, in the meantime, had passed away. And so he approached us before Christmas time, and he said, you know, Christmas is coming up. I have this experience of prior organ donation that was really meaningful to me. My dad received a liver. You know, I kind of want to do something to honor my mom and my dad. And so he essentially wanted to give back in this way. His significant other was very supportive of this choice also. And so he went through that entire donor evaluation process that I laid out for you. So his MEVIS imaging, which is that 3D reconstruction that I showed you, showed that his left lobe and his left lateral segment anatomy were quite complicated with 2 arteries, and we didn't think that that was a safe option for him. And so he was anatomically only a right lobe candidate. His right lobe was actually 1,100 grams, which is very large. It had a single artery, single vein, single bile duct. So anatomically, it was quite straightforward. And it was going to leave him with adequate size of a remnant liver for him to do well. And you'll see that, you know, as opposed to Rebecca, where she was our first case, Chad was in 2000 and I want to say 2000. Oh no, it was technically 2023 because it was after Christmas time. So our experience had really grown since then, and our surgeons were more comfortable doing a larger resection at this point. And so we approved him to be a right lobe candidate. And that anatomy is going to make him too large for most of the pediatric people that are in need, and it can really help an adult. And so when we go through our recipient list, we're able to go through blood type, anatomy, MELD score, portal hypertension, you know, that degree of urgency. And this was allocated to Chris, our original patient, whose MELD was 11 with that significant ascites, and we thought he had a high waitlist mortality risk. His graft to recipient ratio was going to be over 1%, which was going to be great for the degree of portal hypertension that he had. And just to show you our follow-up, you know, this is them afterwards. I think this is only, it was only 2 weeks after the donor recovered, the donor surgery and the living donor liver transplantation. So at 2 weeks, Chad is sitting there across a table at a restaurant from Chris, the recipient, meeting each other for the first time and feeling really good. So what are our current focuses? You know, I kind of emphasized to you that blood type compatibility is very important, but blood type incompatibility can be a real barrier to approving living donors for recipients, that and anatomy. And so our focus here right now is in trying not to limit ourselves. We allow donors to come forward who are blood type incompatible or who we think might be too small for their intended recipient. We'll still evaluate them and we'll talk to them about the idea of a paired exchange, or non-directed donors can also create chains of people. And this is really analogous to what happens in kidney donation and the kidney experience. And so I think that this is huge right now. This week, we are starting a chain here, and I think it is our third or fourth chain or paired exchange to be taking place at the university. We're also part of a national pilot project through UNOS, where we want to be creating those pairs and chains on a national level. So when we have somebody who's incompatible come forward, who's approved, if we don't have somebody that they can do a paired exchange with immediately, we'll offer to them to go into this national paired exchange where the donor travels to the recipient hospital and gets their surgery there. So far, we haven't done one of those yet, but we are enrolling people into that. And that's a really active area where we're trying to collaborate on a national level. Okay, so overall, I've talked a lot, but I really wanted to emphasize to you, not only from the referring physician perspective, when to refer, but also kind of what happens on the back end here, that you don't need to be looking for a living donor for your recipient, that that's an ongoing conversation and that we're doing multiple things in parallel here. So in summary, I would say that living donor liver transplantation confers a substantial survival benefit to candidates on the wait list, even at MELD sodium scores as low as 11 and probably lower, that the life years gained are comparable to or greater than any other life-saving procedure that we do, and that here at the university, there are unique opportunities that are starting to present themselves for our low MELD population. And so just consider referring your patient early so we can get to meet them, get them on the list, and start really trying to work on the strategy of how to get them a transplant. And of course, none of this would be possible without all of our donors. These are just some of them. It's a really inspiring population to work with. If you ever want to see something incredibly inspiring, I would tell you to go and just Google this CVS, A More Perfect Union, and you can look up altruistic liver donation. And this is that first case of Rebecca who donated to Manolo, a little baby over at Children's. There's also just a huge value for living donor liver transplantation at our center. Lindsay's one of our physician assistants who donated to her mother who had PBC years ago and is doing wonderfully. Just seeing these things happen is really inspiring. So if you have any questions, I'm just putting this up here and I am going to try to get to the chat to answer this stuff. So we have at least 10 minutes. So I didn't do too badly with timing. Okay, I see a lot in the chat and then I don't see anything in the question and answer. Lindsay, chime up if I'm missing something. Oh, no, we have not received any questions yet. So usually this is, a topic that gets a lot of people interested in chatting, but it can be a little harder in this forum where I think you're not able to speak as freely. And instead it's just me answering written questions. I am happy to talk anytime about this. I mean, this is something that we're just all so excited about here. So I'll just wait for a minute. I see some questions coming in, so let me just try to see these. Okay. Dr. Lacefield says, MELD sodium versus MELD 3.0 for these decisions currently, which is preferred? That's a really great question. I actually thought about addressing this during this talk, and then I realized it's too broad of a scope for this one talk. But it is really important for you as just referring and managing these people. This is the way that I look at MELD sodium and MELD 3.0. MELD 3.0 is our current mode of allocation. You have to calculate it to know what MELD your patient's going to be listed at. It is the effort of a national effort to try to represent the waitlist mortality to females, and to people whose creatinines don't go up quite as high. And so it's the reality of the system that we have. But MEL 3.0 has been official for all of 1 month. We don't have a lot of data on waitlist mortality with MEL 3.0. And personally, I know that it's not going to be perfect. It's never going to take all the degree of portal hypertension into account. So I think that I make decisions based on the data that's available, and most of the data that I showed you is based on MELD sodium. So when I'm seeing a patient, I say, number one, do you need a transplant? Well, based on your MELD sodium and the data that we know about mortality risk on the wait list, yes, I think you need a transplant. Is it safe? That's why you're here for your evaluation process. Number three, how do you get a transplant? Well, now we go by MELD 3.0, and you, as a female who's more petite, might have increased access than you had before, but this is still where you're evening out. In reality, those MELD points are only going to change, I think you get 1.3 extra MELD points for being a female. So it's not like you're going to see a MELD change of 15 or 5 or 8 to really increase access to transplant. I don't think you're going to see that big of a difference. So yeah, I think that's how I would contextualize how I'm using MELD 3.0 right now. Dr. Everson, thanks for being here. Dr. Everson is our emeritus transplant hepatologist. So he says, very excellent talk. Thank you so much. I think HepQuant might help with some of the discussions in the low MELD group and those being considered for living donor liver transplantation. Absolutely. So this is actually, Dr. Everson, something that I would love the opportunity to integrate into this talk one day. So Dr. Everson now has his own company called HepQuant, which is trying to look at the function of the liver in ways that are not captured just by MELD score or by estimations of portal hypertension based on platelets and spleen size. So it's a functional test of the liver, and I think that that is going to be huge to find that balance of at what MELD score do you really benefit from transplant versus waiting. So I'm really excited to be able to integrate that in one day. Mia Lozada, thank you for being here. She says, I take care of predominantly Native American patients. I have AIAN patient. Have Native American patients been more inclined to accept living donor or deceased donor transplants? I know some of my patients are very hesitant about a deceased liver being in their body from a cultural perspective. Thoughts on death? This is something that really touches us a lot. So great question. I don't know that I'm going to have a perfect, easy answer for it, but let me tell you my overall take and my overall experience so far. Living in Colorado, I never realized until I started practicing here, how we are really a catchment area for such a huge population that's around us. That's really underrepresented in all of medical care, and that absolutely flows downstream to transplant. We have a lot of initiatives that are trying to really interact from an outreach perspective. One of them are these webinars. Also, Dr. Kalra specifically has clinics set up in areas that are underserved. And so we're trying to really, really be active in bringing transplants to populations that have more trouble traveling to us. Now, in general, I would say that population doesn't always get to us as easily. And so I consider them to be underrepresented. And I think Dr. Kalra's outreach initiative is huge for us. What I find about living donor liver transplant as a barrier is that not only does the recipient need a good support system, but also the living donor needs a good support system. And not only does the recipient need to be healthy enough for a transplant, the living donor needs to be healthy enough for a transplant. And so in some ways, it concerns me that living donor, it's almost another hurdle to get over to have a living donor, to have a living donor approved. And the farther away you are, the more underrepresented you are in medicine, the more that hurdle feels significant. That's where I think these non-directeds really come forward and really make a difference. I'm not able to show that in the adult population yet, but I can show it in the pediatric population. So Dor Yoeli is a surgical resident that I've worked with before on the pediatric side. And he and the whole pediatric team have been able to show that the non-directed donors that are eliminating that wait list, they're also helping people that are more socioeconomically disadvantaged. We used a surrogate marker in that study because we only had certain outcomes for socioeconomics in the national database. So in the national database, the surrogate that's used is public health insurance or private health insurance. And we were able to show that those non-directed donors corrected for waitlist mortality in that population. So I think that stuff is happening in living donor to the adult population, but just not on the scale yet. You know, those are small numbers. You can't show outcomes yet with those small numbers. Now you're also asking about your population. Do we find that they're more interested in living donation or deceased donation? In my personal experience, if somebody's coming up here for a transplant evaluation, there isn't a population of people that's been extremely hesitant for a deceased donor. They might actually, phase themselves out or make that decision before they even come here, is my suspicion. So that would be something really interesting to look at from your perspective. My experience with that cultural perspective of living donation versus deceased is really in Asia. And it's a historical thing that's been shown. So when transplant first started, and Startzel started transplant here, there is an acceptance culturally and religiously for most people in the United States to accept a deceased donor. But in Asia, as transplant was starting, that was a cultural and religious barrier. And so living donor is what completely took off in Asia. And Asia has the largest living donor experience. And a lot of actually what we learn from them is based on their experience. As an example, 2 of our surgeons went to Saudi Arabia last year to increase their experience with robotic living donation or living donor hepatectomy, because the volumes there are just so high, because it's culturally and religiously really accepted. So that's something that, I hope that we're able to help anybody who from that cultural perspective has a hesitancy by offering both deceased donor and living donor transplantation to them. So I hope that answers your question. It's very interesting, from a historical perspective, and also just that idea of really wanting to respect where a patient comes from, right? So all of our patients come to us with their own life experiences, and we're meeting them and trying to get to know them so quickly. Avash says, Dr. Kara says, you touched on this a bit, but to further emphasize, who is responsible for finding the donor if someone is felt to be a good candidate for living donor liver transplantation? The patient, the referring MD? No, definitely not the referring doctor. So I wish that, we had a list of enough non-directed donors that we were just handing them out to everybody, and that there was no responsibility on the side of the recipient. But that's not the reality that we're in. We still have an organ shortage. There's nothing that we can do about that yet, other than to continue to educate the general population. So the responsibility really lies on us as the transplant center, having those discussions about risk benefit. We talk to those recipients and talk to them about having discussions with their family. So sometimes I'll call their family and just explain why this is so important. Or what I really love is when the whole family comes to clinic and hears what the recipient's going through and what their options are. And then also we'll kind of guide them through social media and posting on social media. So I can't say that, you know, I wish that it was the situation where I could find this for everybody. It is not at all the referring doctor's responsibility. The referring doctor, I would just focus on get your recipient candidate through the door here, get them evaluated early, start these discussions with us early. That's really the only thing that would be on you. And then in the end, it's really working on the nuances of this with the recipient candidate and their family to see, you know, who is available, what's possible. And ultimately, you know, we have non-directed donors. It has to be the right timing. Things have to work out. But it's obviously helping a lot of people. So I hope that that helps to kind of clarify that. Thanks for saying you appreciate all that we do. We appreciate all that you guys do. I read an article the other day about how really primary care doctors should be the leaders in all healthcare systems because they're the most versatile. They know the most, they see everything, and you're the front lines. So thank you, everybody. And then Lindsay's just reminding us that on September 20th, Dr. Chris is going to be talking about diagnosis and management of clinically significant portal hypertension and its complications. Okay, I hope this helped everybody today. Thank you for joining us. Have a great day.